Oh. Good afternoon, everybody. Hello. Okay, so they can hear me. So hello, everyone, and welcome to the fourth PSGE webinar series and the first of the PSG Karl Storch webinar series, wherein we will feature European experts in the field of minimally invasive gynecologic surgery who have been friends of the PSGE. Our international faculty this afternoon was with us in 2018, where we not only featured him as a speaker, but we also asked him to do telesurgery. And we beamed his surgery from Quirino Memorial Medical Center. This was the second time that the PSGE had a telesurgery during its annual convention. The first was back in 2014 under Dr. Angela Aguilar, who happens to be with us as part of the faculty. So I'd like to thank you, and welcome you, Professor Canis, back to the PSGE. Thank you for graciously accepting our invite to join us this afternoon. Thank you, Karl Storch, for partnering with us. And to Dr. Tonet Habana, thank you again for making this exciting webinar series with Cars with a Reality and for the past 4 successful PSGE webinars. And to continue with the program, let me now introduce the chair of the moderating team. Slide, please. The chair of the moderating team is Dr. Jean S. Godu. She's a fellow of the Philippine Obstetrical and Gynecological Society. She's the Assistant Secretary of the PSGE, an active consultant of the Department of OBGYN of St. Luke's Medical Center, Quezon City, and the Providence Hospital. She's a member of the Residency Training Committee of the Department of OBGYN of St. Luke's Medical Center. Friends, let's welcome Dr. Jean S. Godu. Unmute yourself.
Okay, good afternoon again. It is indeed an honor to be introduced by a hardworking and brilliant president of Philippine Society for Gynecologic Endoscopy, Dr. Prudence A. Aquino. Thank you, Madam President, for the kind introduction. Okay, before I will introduce my co-worker, let me first share to everyone, the webinar house rule. First, participants other than the speakers are muted. Okay. Kindly send your questions via the question and answer and the chat box questions and the questions will be addressed during the open forum. This webinar will be recorded for future viewing. And also, would like to remind everyone that there will be a survey form and a post test, which will be emailed to you by the PSGE Secretary, Ms. Jalen. Now, it is a time for me to introduce to you my co-worker or my co-chair. It is a great pleasure to have Dr. Maria Asuncion A. Fernandez or Dr. Jean Fernandez. Okay? She is a member of our Board of Trustees of Philippine Society for Gynecologic Endoscopy. She is a section head of reproductive medicine at St. Luke's Medical Center, Quezon City, an active consultant in minimally invasive gynecologic surgery, both in St. Luke's Medical Center, Quezon City, and Global City. She is a member of Residency Training Committee in the Department of Obstetrics and Gynecology at St. Luke's Medical Center, Quezon City. Our colleagues, dear colleagues, please meet Dr. Jean Fernandez. Dr. Jean.
Thank you, Dr. Jean Godu.
Your video.
We welcome our esteemed.
There you go.
We welcome our esteemed guest speaker for today, He is a full professor of obstetrics and gynecology since 2003 and in the Central University Hospital of Clermont-Ferrand up to July 1st of 2018. His interest in endometriosis began during his residency, and right now since then he has been involved both in the development of advanced laparoscopic surgical procedures such as laparoscopic radical hysterectomy and excision of deep endometriotic nodules. And also he is involved in basic research on the pathophysiology of endometriosis and of the peritoneal surgical environment. Currently, he is the director of the French National Center for Scientific Research Unit on Computer Vision and Endoscopy, or NCOV, which is part of the Pascal Institute of Clermont-Ferrand, Auvergne, University of France. He has more than 470 researches to his name as either author or co-author. So we will welcome first Professor Michel Jean Canis, and he would be followed by our very own, can you please put the slide of our reactor? Yes, that's Professor Angela S. Aguilar, who is a professor of the Division of Reproductive Endocrinology and Infertility of Obstetrics and Gynecology, University of the Philippines, Philippine General Hospital. She is the president of the Pediatric and Adolescent Gynecology Society of the Philippines, currently the vice president for the Philippine Society for Reproductive Medicine, and the past president of the Philippine Society for Gynecologic Endoscopy. Let us welcome first our international faculty, a World Endometriosis Society ambassador since 2011. Welcome, Professor Michel Jean Canis.
Good morning, everyone. Can you hear me?
We can hear you.
Yes, Professor.
Yes,
Okay.
Professor.
So thank you very much for the invitation. I will start with my presentation. Okay. Okay. So I will try to discuss different, can you see my slides? It's okay for you?
Yes, sir. Yes,
And
Professor.
it sounds correct, okay. So I will discuss some aspects of endometriosis today. I want to stress that I'm talking as a representative of our department. There is no more head of department in our department in gynecology in Clermont-Ferrand. We are all working together. So there are 10 people participating to the management of the department. So I'm speaking on behalf of them. I first want to thank you for inviting me, and particularly thanking Prudence. We had the opportunity to meet together in Okayama a few years ago, and I think it's a very nice cooperation and very nice to meet you again. Although when I see these pictures, I would probably prefer to be again in your country than to be in my office, but that's our life of today. Of course, it's impossible to discuss everything about laparoscopic surgery and endometriosis. The field is very large, but I will try to discuss a few points, briefly discuss about COVID-19 outbreak and what we should learn from this episode. I will also discuss endometriosis surgery in minimal disease because I think surgeons are lost. I will try to bring you new data and new very exciting pictures using fluorescence about the trauma to the ovary induced by endometrioma surgery. And I also will show you identification of the limit of deep disease using both knowledge of what we should know as signs of complete or incomplete surgery, and also new techniques using the Rubina methodology. So what about COVID? It's being a big change, and it's changing every day. And I think we should be very, very careful about any guidelines or conclusions. If you look at this slide, you see that since the beginning of the year, there have been more than 40,800 papers. And you see that between the 13th and the 15th of August, it's 558 papers in 2 days. It means 279 papers a day. So obviously it's changing very fast. And when we compare to endometriosis, which I think before was a quite changing problem, that's only 28,000 papers since 1927. So obviously this is a big revolution. Everything is changing, and we should be very careful on any conclusion. Anything I can say today may be a big mistake for tomorrow morning. So about surgery for benign disease, I think the first lesson that we have, and the first question is should we or may we operate? Obviously, patients who are operated and who have COVID-19 disease around surgery a few days after have a very high rate of complications. These papers were reports of case reports mainly, but we now have more large studies. One from the JAMA surgery, which showed that this is a case control study, which showed that death rate of patients with COVID-19 is quite high, about 20%. Of course, this is not gynecologic surgery, but it clearly emphasized that there is a risk to operate a patient who may have the disease. So we should be careful when selecting our patients. Here is the slides, another slide confirming that COVID-19 is the main factor of postoperative complication, much more than anything else like age, sepsis, or other classes. So obviously COVID-19 is a major factor of complication, so we should avoid surgery. And this was confirmed in the Lancet paper, a large study about 1,100 patients, which showed again that the complication rate after surgery could be very high if the patient contracts the disease a few days after surgery. So obviously we should be very careful when selecting our patients. This is not so easy. In France, we use an auto questionnaire, and patients are asked to answer a few questions about fever, cough, anosmia, and things like that. If they say yes to it, then there are things to be, they are designed and described as being at risk of the disease, and then PCR test is done. If PCR test is positive, the surgery is postponed, and if PCR test is negative, and if there is no clinical signs and no close contact with the patient within the few days of surgery, then the surgery is done. But we are careful in selecting our patients. And I think also we should stress that for cancer patients and very heavy procedures, COVID test and PCR test is done routinely, whatever the clinical symptoms of the patients. So we are careful in selecting our patients. The second question, which appeared at the beginning of the outbreak, was should we do laparoscopy or should we do laparotomy? You probably heard about this very careful statement of AAGL board, which said that many patients should be converted to laparotomy to prevent the dissemination of the aerosol. What for? Obviously, we have very controversial data about the presence of COVID-19 or SARS-CoV virus in the blood, and the range reported is from 1% in this JAMA paper to 40% in this emerging microbe and infection paper, and that's very different. So we don't know really what is the rate of the incidence of virus in the blood. We do know that there may be a lot of virus in the digestive tract, as shown by this JAMA paper, very recently published. It's about 40% of patients with the disease who have virus in the feces, so it's quite high. For the peritoneum, the first paper were very reassuring, with all papers were negative, but recently two papers were reported last week where COVID-19 virus was found in the peritoneum. So probably the virus could be there. We know also that the virus may be transmitted through aerosol. It's a paper published at the beginning of the outbreak in the New England Journal of Medicine. And obviously SARS-CoV-2 may also be transmitted by aerosol. This question is quite debated, and in Nature, they concluded that before we get complete evidence about that, it would take years. So we should be careful and accept that there is probably a risk of aerosol of the virus. This paper is very interesting, showing that when we cough or when we sneeze, the gas is going far away, and we are all speaking about droplets. But when we think about droplets, we should think that this is something which is dynamic, because the droplets contains water, and this water may disappear and may evaporize, so that the droplets may become a virus particle. So obviously there is a risk, and we should be careful about it. That means a minimum number of personnel in the operating room. All of them should be very carefully protected if we have to operate a COVID-19 positive patients because of an emergency surgical procedure. Intubation should be done in the OR, and the room should be kept closed during intubation. We can use positive pressure room, but if you do intubation in the OR and a positive pressure room, you should wait for 5 minutes before opening the door. Because if you have a positive pressure, you should have a ventilated room. And in these ventilated rooms, the air is completely changed in about 5 minutes. So that's the reason why we should wait after intubation. And for the surgeons, two big rules, very simple: prevention of any peritoneal leakage as much as possible. And it's up to you to know what procedures that you may decide to do may be at risk of peritoneal leakage. You should minimize it as much as possible. And probably the big change for the future, we will have to take care of surgical smokes. We have been living with smokes without taking care of them for years, but this will have to change. I'm sorry. Insufflation and trocar initially is not different because CO2 is not at risk at the beginning. There is no reason for virus in the peritoneum, or very, very low, so it's no problem at the beginning. Then you limit the number of incisions whenever possible, but you should get enough port to do effective surgery to avoid very long surgery, unnecessary long surgery. You should ensure that incisions are of appropriate size to prevent leakage. You minimize the exchange of instruments, again, to minimize leakage. You use ancillary trocars with balloon, which is probably a good idea to prevent accidental trocar removal, and the pressure inside the peritoneum should be as low as possible, possibly around 8. If you use electrosurgery, many guys are saying, okay, you should use minimal electrosurgery. I think we should do adequate hemostasis. These patients are fragile, and postoperative bleeding would be a major complication. So we should do effective hemostasis. And when we discuss that with experts in electrosurgery, like Revaz Buchoresvili working in our department, he says, okay, you can use bipolar surgery, because bipolar surgery is only desiccation, it's not vaporization, so that you are not producing an aerosol, you are just desiccating the tissue, so the risk is much less with bipolar surgery if you use a correct setting. Electrosurgery has the advantage of a high temperature, which can also destroy the virus. So prefer bipolar surgery and do effective hemostasis, and probably preventive. Laparoscopic vaginal incision is probably something which should be almost always avoided in COVID-19 positive patients, because this is a procedure where it is very difficult to prevent peritoneal leakage. Ultrasonic dissection is inducing an aerosol. It may not be the best approach, but this has to be discussed by experts of this technique. I'm not an expert of ultrasonic dissection, but we don't think it's a good idea to use it every day. You should collaborate very well with your anesthesia team. Obviously, the patient should be effectively curated and relaxed so that the intraperitoneal pressure will not increase suddenly, and this would be at risk of peritoneal leakage. So very good collaboration with the anesthesiologist is essential. The vagina should be open and closed vaginally. Really, I think this is very important. And then we should manage the smokes because these particles could be in the smokes. We know that there are smokes from hepatitis virus and from HPV virus in the smokes. And we know that some surgeons have been contaminated by HPV virus during surgery. So obviously we should manage our smokes much more carefully. There are very different machines to do that. Most of these machines are using ULPE filters, which are mandatory to be effective, probably, much more than the other ones. And you have different types of devices. I'm not going to discuss them. Some are connected to the insufflation machines. Others are connected to the electrosurgical units. Others are passive smoke evacuation devices. These ones are very cheap, but very effective. You should be able to adapt the flow. I think this is important to prevent overventilation or overuse of CO2. You also have this electrostatic technology, which would be very attractive because the virus is precipitated on the tissue inside the peritoneum, so no more present in the CO2. This is a very attractive tool, but we don't have very large studies about it. And at the beginning of the outbreak, many guys design homemade device like this one published in the Annals of Surgery. We also design one in our department. These homemade devices have the main disadvantage of a continuous evacuation, which is not very good because it means very high flow of CO2, very high consumption and use of CO2, and a high risk of drying of the peritoneum. So I really think we need something which is a smoke evacuation which should not be continuous. The flow should be adaptable to the procedure, and we should not have a continuous CO2 high flow because this would be very bad for the peritoneum. We would dry it and traumatize it. So we should avoid that. But our life is going to change. Our management of smoke is going to change forever. Should we do a laparotomy or a laparoscopy? Well, I think that laparoscopy is better because it's much less traumatic. And as these patients are at risk of complication, it's probably better to decrease the trauma. And also, it's more difficult to aspirate and to contain the smokes at laparotomy. And in fact, we are breathing much more smokes during a laparotomy than during a laparoscopy. You also should take care of the filters used on your aspiration device. This is very interesting and very important. And this is probably one of the weaknesses of all our surgical device. This is the filters on the aspiration lavage device. And this is essential to prevent and to prepare our, to protect our personnel staff and the staff of the theaters, because when they manage the aspiration device, very often they can be contaminated if the filters are not adequate. Well, now we'll discuss endometriosis. And well, I would like to propose you that surgery is a good alternative to any kind of treatment. And I think today that because medical treatment is very highly promoted by many speakers, because the disease is supposed to be progressive, because the disease is supposed to be recurrent, surgeons are lost. They are no longer sure that they should operate endometriosis patients. Whereas we should know how to manage most of our patients And most of our patients have minimal, mild, or moderate disease. This is a prospective cohort in Auvergne, our region, our geographic area. These are patients who were operated for the first time, and you see that most of them had minimal or moderate disease. So what should we propose to these patients who are not supposed to have severe disease? Should we do surgery for them? So when you have a question, you go to the literature. And when you go to the literature about endometriosis, we are very lucky nowadays because there are 3 reports in Nature. One from Paolo Vercellini, one from Crina Zodnovan, and one from Charles Chaperon. And what is very interesting is that they all disagree. And they don't explain you what you should do. Charles Chaperon is promoting a medical treatment without surgery unless absolutely necessary. Paolo Vercellini is rather surgical in his attitude, and Crina is in the middle. So even the literature is very rich and very well documented by world-renowned experts. You have no conclusion about that. They disagree. Charles Chaperon, again, is claiming that we should not do surgery, and Paolo Vercellini accepts that even hormone-dependent pain may not be related to endometriosis. What does it mean? It means that the patient has severe pain. You give her, for instance, GnRH analogs, the pain disappears, but it does not mean that the pain was related to endometriosis. It's an hormone-dependent pain, but it could be another cause. So experts disagree. So what you should do when you see this minimal disease at laparoscopy, should you treat it or not? In patients with severe dysmenorrhea, very high visual scale, very high score of pain, associated bowel or urinary symptoms, acyclic pain sometimes, absenteeism from school, lack of participation in daily activities, and you have a normal MRI. What should you do? What should you do? Excision of this is very simple, you know it. So in such case, if you do a laparoscopic diagnosis, it's easy, simple, you confirm whether or not the patient has the disease. If you confirm the disease, you confirm that it is not severe. You confirm that fertility is going to be normal. So you confirm that the treatment would be viable. But many guys today are saying, no, you should not do a laparoscopy. It's too risky. And these small lesions had no impact on pain. And furthermore, there is a high risk of recurrent endometriosis and a high risk of recurrent pain. The risk of surgery is about 2 out of 100,000 cases, so very, very low, and probably lower today as laparoscopic surgery is taught with more effective methods and more people are trained, so probably the risk is lower. What is the alternative to surgery? The alternative is a presumed diagnosis, is a very long medical treatment with years of hypoestrogenism, with years of fears, and with immediate and long-term consequence of possibly unnecessary medical treatment. Is it much better? Is it much less risky than surgery? I'm not sure. Because you know that today, many guys are recommending to use progestin-only pills without estrogens. Well, I do think that women needs estrogens in life. Also, these hormonal treatments, which are progestins, have impact on the bone. This is a study which showed a loss in bone mineral density after 6 months in adolescent and 6 months of dienogest or 6 months of Visan, and you see that there is an effect on the bone. You also think that these patients are very young and that their bones are not completely finished. So we should be very careful when using this kind of drugs. When discussing bone loss, I think we should go back to a very old study. This was a study published in Bone in the 90s, 1995. And this study, which used a bone biopsy before and after GnRH analog agonist concluded, our results suggest that bone loss induced by GnRH analogs may be associated with adverse effects on cancellous microstructure, which are unlikely to be reversed following cessation of therapy. Okay, so when you assess bone density using radiologic measures, everything seems to recover, but from this study done by rheumatologists and published in a rheumatology journal in 1995, they doubt that the damage may be repaired. So we should be very careful when we use a long-term medical treatment with a very low estrogen level in the blood. These results, I'm sorry, were observed after 6 months of treatment. But when you guess that an 18-year-old woman has endometriosis because she has severe dysmenorrhea, and you decide a medical management until she wishes to become pregnant, you may decide a medical treatment with hypoestrogenism for 10 years because she may wish to be pregnant only after 30 or even 35. So it's a very, very long medical treatment, very long hypoestrogenism, and we have no idea of the effect of such a treatment. So surgery may be at risk, but how risky is such a long medical treatment? I don't know. Of course, progestins also have other side effects. In France, we do have warnings about progestogens and the risk of meningioma. At the beginning, it was only for cyproterone acetate. It's now also for chlormazidone. And I'm quite convinced that on the long-term basis, we will have warning about progestogen and meningioma for any of them. Also, weight gain is quite a problem for this woman. I do have prescribed progestogen in young patients for years because we were using it a lot. And after 10 years, their weight gain is very often 10 to 12 kilo. And for them, it's not so easy to change that much in their body appearance. Also, you have the complication of fear because you explain to these young women that they have a mysterious, enigmatic, unknown, unexplained, recurrent disease which induces chronic, painful, chronic pain, dyspareunia, and also infertility. So they are afraid of it, and because they are afraid, the pain is increased. And many of them don't have the disease. So if you instead, in such case, if you have severe pain and you don't know the cause, you may decide to do a laparoscopic diagnosis. This is not so complicated. You confirm the diagnosis, you confirm that the disease is not severe, you confirm that fertility is probably normal, and also you can treat the disease. And we do have evidence that treating the disease is improving the patient's life. We do have prospective randomized study from the Sutton group a long time ago and another one from the Abbott group in Australia. They confirmed that surgery is indeed improving the patient's quality of life and pain score. And these were prospective randomized trials. We also do have the evidence from a study from Berkeley, who published in Pain in Science a long time ago, and she clearly showed that even minimal endometriosis in an animal model is worsening a chronic pelvic pain. So we do have evidence that even minimal disease may induce or worsen the pain, and if treated, improve the results and the clinical life and the clinical results of the patient. So surgery could be useful. So there is a rationale for the treatment. I know. You're saying treating so tiny lesions will not influence postoperative pain. And I do agree. When endometriosis is minimal, associated causes are likely to be associated to explain the clinical signs. As we all know that associated infertility factors are more common in patients with minimal disease than in patients with severe disease. But remember, before deciding the procedure or before the procedure, you saw that the patient has severe pain because she had endometriosis. And you don't want to see it. And now when you see it, you don't want to treat it. You change your mind and you think that treatment is not necessary. I don't think it made sense. Before surgery, endometriosis was the main cause of the disease, and now you see it and you don't want to treat it? Strange. You think the disease is not severe enough to explain pain. Okay. But before you think that the pain was severe because of the disease, you are lost as a surgeon. So I think surgery is not useless and you should treat them. Okay. But you think treatment is useless because the disease is progressive, so it will worsen after my surgery, and because the disease is recurrent. May we discuss these two aspects? Is it always a progressive disease? Well, if you look at these studies in an editorial of Jan Evers, from at the time he was the editor-in-chief of Human Reproduction, and he was discussing a paper from Ivo Brosens about adolescent endometriosis, and he looked at all the control groups of the prospective double-blind randomized study of any treatment of endometriosis. And he clearly showed that most lesions are regressing, that many lesions are stable, and that very few patients have progressive disease. So it's not always a progressive disease. I also discussed this paper with Professor Ariashian, and this study, published again in Human Reproduction, is a study done in baboons. You know that baboons have retrograde menstruation, and he was repeating laparoscopy to see whether or not the disease was worsening over the time. And when proposing my hypothesis about trauma and laparoscopy and trauma and endometriosis, I thought, well, this worsening of the disease at repeat laparoscopy is the consequence of surgery and not the consequence of the spontaneous evolution of the disease. And I was lucky enough to be able to present this idea to Professor Ariashian in Pattaya 2 years ago. And he said, at the end of my presentation, he said, Michel, I agree with you. This is the consequence of repeat laparoscopy. This is not the consequence of spontaneous evolution of the disease. And this is a major argument, you know, because most of the ideas about progressive disease are coming from studies done by Thomas Doge in Kenya when he was repeating laparoscopy. And I remember Ivo Brosens presenting me his results, and he said, you know, laparoscopy shows that endometriosis is appearing and disappearing like mushrooms. And no, it's not like mushrooms. It appears on place that you touch with your laparoscope or with your instruments because you traumatize the peritoneum, and it disappears because it's able to spontaneously heal. And if you understand it in this way, no, endometriosis is not a progressive disease. So you may be careful. Do we have evidence that the disease is progressive from epidemiologic data? Again, back to the prospective cohort of ovarian. If you look at the incidence of stage 1 disease, of course, it's very high in less than 20 years old women, but after you see that the percentage is fairly stable, not different. So obviously some patients have a beginning disease or something very limited, although they are 40 years old. If the disease was progressive, this percentage should be steadily decreasing, and this one should be much higher and progressively increasing. And we don't have this aspect at all. We have very stable percentage and higher in patients who are older, because obviously we operate patients only for hysterectomies at this age, so we select the patient. But if you look at this, you don't have the impression that this is progressing. So we don't have evidence that the disease is progressive. You don't want to treat it because you think it's recurrent. Okay. But if you look at Patrick Young's paper, who excised completely the disease and who repeat laparoscopy because of recurrent pain, he showed that most of the biopsies were negative. No recurrence at repeat laparoscopy. So no evidence that the disease is recurrent. So my idea of trauma means that if you want to have a recurrence, you need a recurrent trauma. I don't have time to discuss this in detail, but if you want to read it, you can go to this paper. If you look at long-term fertility of patients treated during adolescence, you see that Alain Audebert reported a 72% pregnancy rate, and that the group of Tommaso Falcon reported an 80% fertility rate. It means if the disease was progressive, if the disease was recurring always, would you think that the pregnancy rate would be that high? No, it doesn't make any sense. So we don't have evidence that the disease is always progressive and always recurrent. So we do have arguments in favor of a surgical treatment of this early form of the disease. Yes, I know pain will recur. You did not treat all the gynecologic cause, and especially the uterus has not been removed because you want to do conservative surgery in the young patients. You did not treat all the associated cause, and especially violence, sexual rapes, whatever, trauma to the patient and trauma to the woman. These associated causes were so important when facing the lesions that you concluded that surgery was useless. And now you don't want to include them to explain recurrent pain? No, it should make sense. These are the cause of recurrent pain. So recurrent pain is not the proof that the disease is recurrent. It's not the proof that the disease is progressive. It's not an indication for another laparoscopy. Remember, when facing the lesions, you felt that they were too small to explain severe pain, and now you change your mind and you want to see again the pelvis? No, no rationale. You did the treatment, you have no evidence that this is always recurrent. Don't repeat the laparoscopy. Look for other causes of pain, and there are many of them. Why should you change your mind? Well, you no longer see the pelvis. Try to be steady. Try to be logic in your management. So on minimal mind disease, I think that confirming or excluding the diagnosis may be useful for the patient. They know that they yes or no have the disease. They know that in most cases it's not severe, that it will not impair their fertility. I think if you do a laparoscopy, the surgical treatment should be achieved and be as complete as possible. You should look for associated cause of pain and be very careful with the previous personal history of the patient. Many women had a trauma during infancy or during adolescence, and this may be associated with severe pain. Do remember that there is no rationale to explain recurrent pain by a recurrent disease, and there is no rationale to perform a second and even third laparoscopy. However, I think a long-term estrogenism has significant side effects and years of fears because of a potential disease which is probably benign, non-recurrent, and which could be easily treated at surgery. These years of fears are useless and unacceptable for young women. So excluding the disease and diagnosing it may be very useful for the young patients, and you will have much more argument to decide that other causes of pain, such as violence, should be looked for and managed. And this is very often difficult to be accepted by young women to relate their pain to difficult situations during their infancy or during their adolescence. Of course, the more severe the disease, the more argument we have to treat it. And you know that the Abbott studies included deep disease, and he showed in a prospective double-blind randomized studies that surgery is useful. Also, the group of Ross-Roman showed that surgery for deep endometriosis, but easy to treat, is very effective with no bowel involvement. We have deep disease without severe involvement, and the treatment is very effective on pain, and we should propose it. Ovarian endometrioma is another situation. Surgeons again are completely lost. What we know, We do know that endometriosis is damaging the ovaries. There are numerous studies showing that. Even Dr. Boulogne concluded that ovarian endometriosis is the nemesis of eggs. So obviously we do have a lot of evidence. And the first study who showed that the endometriosis is damaging the ovary is a study from Sachiko Matsuzaki from our department. All these studies confirm that endometriosis is damaging the ovary. We are afraid of decreased ovarian reserve after surgical treatment of endometriosis because of IMH. We are afraid also of a few case reports of ovarian failure after ovarian surgery. But we do forget that many studies showed that even after surgery, you have no difference in ovarian reserve or in response of the ovary during IVF treatments. And many studies also showed very good delivery rate after surgical treatment of endometriosis, including patients with ovarian endometrioma. So we do have evidence that the surgery is not always traumatic. We do know that fibrosis, as stressed by Paola Vigano from Milan, that fibrosis is severe, and we do know that fibrosis may damage the ovary and may damage the vascularization of the ovary. But fear is stronger. Nowadays, surgeons are accused of damaging the ovary, and you know, a surgeon needs confidence. A surgeon spends more time on complications than on success. And also a surgeon, as anyone, is sometimes lazy. So it's much easier to say, okay, no, I'm not going to do surgery because I'm afraid of it. People are accusing me, so I'm afraid of it. So you will ask for MRI, and you will look at the presence of deep lesions, which explains severe pain, and you have one more argument for surgery, and you will ask for IMH. Well, you ask for IMH, whereas you know, IMH is produced by primary follicles, not by primordial ones. And you know also that the correlation between the levels of IMH and the number of primordial ovarian follicles was established in mice. But even in mice, it was not confirmed during the early reproductive period. And this again is a paper from Nature. You know that you have no evidence to confirm that the signification of a low IMH level in a young patient with a cyst should be interpreted as a low IMH patient in a 47-year-old woman. Do we have any evidence, do we have any hypothesis to explain that the unilateral ovarian endometrioma may compromise the ovarian reserve in a patient who is less than 30 years old and has two ovaries with a normal contralateral ovary? I don't understand that. May we hypothesize that this reflects an ovarian repairing process? May we remember that our knowledge of IMH physiology is limited so that any clinical conclusion appear premature. So what should we do? If there is a low IMH level, most guys will say, okay, you should do oocyte preservation and IVF. Whereas this is very strange because we do know that when the IMH level is low, IVF is difficult to organize and the response will be poor. Okay, the guys of the IVF department are going to increase the dose, and this is the only reason why IMH is useful. How do you want to stimulate the ovary to prick up the oocyte? If the IMH is low, you should increase the dose. This is the only use of the IMH level. Okay, so I will go faster on that, but we don't yet have any evidence for that. We do know that you can do IVF with an ovarian endometrioma since this paper of Garcia Velasco a few years ago. This was an editorial from Garcia Velasco and Somigliana, but okay, you can do IVF with ovarian endometrioma, but up to which diameter? Very interesting study from the Valence group about oocyte fertility and vitrification for fertility preservation. And good results in patients with endometrioma? Yes, but look, diameter of ovarian endometrioma larger than 1 centimeter. Has everyone decided surgery for an endometrioma of 1 centimeter in diameter? No. Is it more difficult to do it when the diameter is larger? Yes. And this is a recent paper from Sumigliana, very in favor of IVF in the management of ovarian endometrioma. And he clearly said and published that if the diameter is above 4 centimeters, then the IVF problem is more difficult to achieve, and that surgery may be discussed. So what should you do? No treatment, surgery, IVF, medical treatment, sclerotherapy, oocyte preservation. If you do no treatment, it's probably not a good idea. This paper from Roberti Maggiore clearly showed that the diameter is increasing. And again, expectant management is in patients who want to get pregnant and have severe disease. The fertility pregnancy rate, the pregnancy rates are so low that no treatment is not an alternative. Medical treatment, okay, medical treatment has no effect on the size, has never been evaluated on a long-term basis, what means you find a lady who is 20 years old, she has a 5 centimeter endometrioma, and you give her medical treatment for 10 years until she wants to get pregnant. What is the effect after 10 years of medical treatment? We don't know yet. This could be a good alternative, but yet we don't know. And I just want to remind you that there is an effect of fibrosis possible and that medical treatment is not effective on fibrosis. So we should assess that before proposing it as an alternative to surgery. So if the cyst is more than 4 centimeters, you know that surgery will be indicated when the patients will wish to be pregnant. You want to avoid surgery in a young patient? Is it better to do it after a long medical treatment? I don't think so. We showed a few years ago that the damage to the ovary was much more risky in patients who receive preoperative medical treatment. So this is probably not a good choice to use a very long medical treatment in young patients to delay surgery. Surgeons are afraid. They are ready to use non-validated alternatives, like sclerotherapy. Sclerotherapy is there for many years. And you see, this is a prospective randomized cohort pilot study, a prospective cohort study, multi-center, and only 33 patients, although there were numerous centers, so inclusion is not so easy. Sclerotherapy may be promising, but what is your method to differentiate endometrioma and corpus luteum? Cytology is not reliable. How often do you perform sclerotherapy on functional cyst? We don't know. What is the effect of alcohol on functional cyst? We don't know. What do you propose in large cysts, which are often very difficult to empty using a vaginal puncture? Well, you may decide to do surgery and prefer optimistic will to pessimistic intelligence. You may remember also this study from the Falcone group, who showed that IMH levels are recovering after 1 year, or the study from this meta-analysis from Ludovico Muzzi in Rome, who clearly showed that antral follicle count is not reduced after a surgical treatment. So to decide surgery should be rational, but does not imply a one-step procedure. You need to use a microscopic laparoscopic approach. Cystectomy may be impossible. Ablation of the cyst wall using CO2 laser or plasma jet may be an option. Both techniques may be combined, and partial cystectomy should be preferred to ovarian damage. I will jump on this one. This is not an easy stripping. Dissection is often difficult because of fibrosis. You should look at the arrows on the cyst wall. Here is the cyst wall, here is the ovary, and here you see arrows showing you where to go and showing you where to look for the plane. Here is a recent example that we did. This patient has a 9 centimeter ovarian endometrioma on the left side. I will run the video, okay? So you look here, and again you see here. Okay. And now the dissection, and you will see that this is a very slow and very gentle procedure. We are moving slowly, not pulling firmly on the cyst and on the ovary. No, looking for the plane, dissecting, you coagulate on the cyst wall, and then you find the plane closer to the cyst than you expect. Again, you work on the cyst wall at the top of the arrow, and then you dissect and you find the plane. And bleeding should be minimal. If it's bleeding a lot, it means you are not in the good plane, you are lost. And because you are lost, you should look again for the plane. Okay, moving slowly and under permanent visual control. This is very important. Again, you coagulate on the cyst wall and you push gently, slowly moving. This is micro dissection. This is not a simple cyst as a serous cyst or a teratoma. This is often very difficult to dissect. Okay. Again, when the dissection is too difficult somewhere, you go somewhere else. You need a very good assistant, but he expose, he don't pull. And again, you find the plane close to the cyst wall, not in the depths of the ovarian tissue. I just show you this step because at this moment, I was lost. I didn't know where to go for the dissection. And you see, I carefully tried to find the plane. Well, where is the cyst? Where is the remaining ovary? It's not so easy to identify. This was not 10 years ago. This was a few weeks ago. And the dissection was not so easy. And I was doing it, not a resident, myself. And you see that the dissection and to look for the plane was not that easy. Now we see it again, and we are going to be able to finish and to complete the procedure. Okay? So you see even a guy who is quite trained, maybe lost during the excision and the dissection of an ovarian endometrioma. And this also is very important because on this part of the dissection, you see the final part, very often close to the ovarian hilum and very often close to the uterovarian ligament. And again, you see that this part may be very difficult. And this, again, we are very careful, very cautious, trying to find the plane and looking for it. Again, looking for it on the cyst wall, not in the depths of the ovary. I want to have meticulous hemostasis because I want to be able to see the plane. If everything is bleeding, you lose the plane and you don't know where to go. And when dissection is too difficult, I decided to cut because I accept to leave part of the cyst wall behind, because I prefer to leave part of the cyst wall than to damage the ovary. Because for a young patient, it's much more important to preserve the ovarian function than to remove all the ovarian endometrioma. It's a benign disease, and you can leave a few millimeters of the cyst inside the ovary at the end of the procedure. Make hemostasis there because bleeding and postoperative complication is obviously a major damage for the ovary. And then you will coagulate and cut this part. Again. But more exciting is the next picture of it. This was very important in this patient because you may have noticed that on the right side, the ovary is very, very small because she had been operated before in another department. She had a postoperative bleeding. They coagulated a lot the ovary at reoperation, and there is a big damage. Conservative surgery may also mean strange decision. You see that this patient has a nodule on the left uterosacral ligament. I know from previous preoperative evaluation that this nodule is going through the vagina. So it means if I excise it, I take the chance of opening the vagina, I take the chance of infectious complication, and I don't want to take the chance of an ovarian abscess because this is the only ovary of this patient. So for her, I decided not to treat the nodule during the same procedure. I told her it would be too risky to have an ovarian abscess, so I said, no, I'm not going to do it at the same time. And now we come to what I think will be the future, because we have a protocol, a prospective ongoing study to assess indocyanine green at the end of ovarian surgery to assess ovarian vascularization at the end of surgery. So we use Karl Storz SPICE video camera. We inject indocyanine green in the blood, and the anesthetist is injecting it. And you see that the ovary is not bleeding a lot. This is the end of the surgery, and you see it's not bleeding. And now we wait for the green light. And this picture is magic, you're going to see. You see the green light arriving, and look inside the ovary. Everything is green, well vascularized, similar to the uterus, with almost no difference. So the damage and the coagulation to the ovary because of the surgery does not appear to be so severe. We didn't destroy this ovary without surgery. Obviously, no. And also you see that fluorescence is a major tool for the surgeon because you can assess your damage, you can assess physiology, and this is really essential for the future. We have one more tool to understand what we do. We are able to assess the vessels, and this is a major tool for the future. Okay, you see here, there are black spots. Black spots means no vessels and low vascularization. But if you look at the same picture before the green, you see in fact that these are small hematomas. It doesn't mean extensive coagulation. It means small hematomas inside the ovarian tissue. So it's not the consequence of surgery, of coagulation and of damage. It's just a small hemorrhage. And we have the same here. Look, these are the two areas which are black. So obviously the damage is not so severe. But as said, when you dissect, the cyst is here, the ovary is there, you should follow the small arrows which guide you to the correct plane. So this is essential to do it in the good way. Cystectomy may be impossible. In this case, cystectomy was impossible. When cystectomy is impossible, you may use plasma jet ablation, like in this case. This was after a preoperative medical treatment, and you see that cystectomy was impossible. So we ablate the disease with plasma jet. This is very elegant and fast. This is a little bit expensive, but this is very interesting. If you have no plasma jet, you can use CO2 laser with a fiber, as reported recently by the team of Canis. You see this very large, this ovary after treatment of a 7-centimeter cyst. And you see that it's obviously very effective, very well preserved and not damaged. So obviously we can do a lot of things. Ethanol sclerotherapy could be a future, we will see, but this needs to be further evaluated. We need to teach surgery. Obviously, this is essential because surgeons who are expert and trained are much less afraid. What to do about deep disease? Again, surgeons are lost because complications are overemphasized. Although we do know that deep disease is very painful. I don't know if you saw this picture. This is the consequence of a vaginal examination during the initial step of a laparoscopic treatment of deep endometriosis. And you see that the clinical examination induced severe bleeding. You can imagine what happened at night during intercourse. I am just like Horace Roman. I can't imagine that patients who have so very deep disease extending to the pelvic wall don't have pain and can be treated medically. Surgery is required. But complications of surgery are overemphasized, much more than the very significant improvement that we have. So surgeons are afraid, and fear is a very strong feeling, whereas the surgeons need confidence, especially when he wants to do a difficult procedure. So we need to encourage them to do surgery. We tend to decrease our indications today. People want to propose 20 to 25 years of hypoestrogenism, and surgeons are blamed because of the complication. Everyone is forgetting the success and overemphasizing the complication. Here is an example for excision identification of the limit of the disease and what we should do. You see this little retracted area in the posterior cul-de-sac. This is a very difficult nodule to deal with. When you begin the dissection, you see the fibrotic tissue in the retroperitoneal space, and you understand that this is indeed deep disease, and you see that it's retracting a uterine vein, which will have to be coagulated. Although it was looking like nothing at the beginning, you see that it's not so simple, because here is a nodule and here is a rectum, quite close to it. It's not so simple because you need to open the vagina, and the vagina is open there. And it's also not so simple, and mainly not so simple, because at the end of the day, the deeper part of it was very close to the hypogastric vein. So what appears very minimal at the beginning is in fact something difficult. And when dissecting, what we thought was the deeper posterior part of it, we suddenly saw small cysts. You will see black spots when cutting here. And these black spots mean that we are not excising completely the disease. You see that the access is difficult because the scissors are fighting with the laparoscope because it's very deep and very posterior. And now you see that you have black spots there, okay? It means that if you don't excise this part, the treatment will not be complete. Again. You see the black spots here and here, so everything should be excised if you want to be complete. But be very careful because you are posterior, you are lateral, so you are very close to the hypogastric vein. So this is a very dangerous area. Okay, so now you may have the impression that you have almost finished, but again, you have black spots when cutting. You see the black spots there. And here you can decide, okay, I remove only the anterior part of it and I leave the posterior one. Okay, but I cut it in two pieces because in one piece it was too difficult and it's easier to manage this part in two pieces. And at this point, after excising everything on the vagina, excising everything on the rectum, now I have to make a decision. Should I excise this part on the hypogastric vein? You know what I did at that time? I called a friend. I asked Nicolas Bourdel to come in the OR and to give me his advice. And he said, Monsieur, because he's supposed to call me sir, I think you should excise it. And to do it, you should cut the vein. I say, thank you, Nicolas. This was also my idea, but I need your assessment and your advice. So he was in the room to help me if it was too difficult because of the bleeding. And we were two of us associated in this difficult step. Then we use a second clip, and we were able to excise this part of the nodule on the hypogastric vein. Remember this picture. It's very deep, very lateral, and very posterior. Even if you don't see them, veins are very close, and they are very difficult to control if you don't dissect them before the bleeding. So if you are in this area, be very careful. First, identify the big vessels, and then go on with your dissection. If you are not expert in this kind of surgery, probably don't go there and stop to do the procedure. It's a difficult one, but it's very interesting because you see the black spots in the deeper part of it, and you see that if you were not excising this, the treatment would not be complete, and probably pain would not be back. This would have been interpreted as a recurrence. No, this is not a recurrence. This would be persisting disease. Of course, the treatment is difficult, and every one of us has a limit. And as just said, my limit is close to this place. And that's the reason why I asked Nicola to come in the OR and give me an advice. We all need some help sometimes. This is the final procedure. And you see we are behind the rectum. This is an artery below the hypogastric vein. And you see that the tissue is almost normal. Well, I think the treatment is quite complete. Okay? Now, another way to look at the limits. This is a large rectovaginal nodule, and we treat it using the Rubina camera from Storz. So this is a paper which is going to be published very soon on fertility and sterility, and you will have access to this paper. But I will show you how we use indocyanine green to assess the limit of the disease. So we are in the shaving part. The nodule is free from the vagina. It's up. And now you need to know where is the limit of the disease. And look at what you can do with fluorescence. This is really very interesting. You see that the green is coming in the ovary, in the rectum, I'm sorry. Look. And that the nodule is black. So the nodule has very few vessels, and the rectum, normal tissue, has a lot of vessels. So you should excise the black part, and you should leave the green part. The black part is abnormal fibrotic tissue, and the green part could be left behind. So this is a very interesting video. I think this is a major guide for the future of surgery of deep endometriosis. And really fluorescence will be a major tool for us. You see that the guy is really following the green. Okay, he's also following the arrow, because you have an arrow of rectum showing you where to go. But when you see it, you know where to excise, and you have a guide from the fluorescence. And this is really, I think, a major tool for the progress, for the future. Okay. Now here is the rectum in the lower part, and the nodule is up. Okay. You have this paper in fertility and sterility available online very soon. This is an accepted paper for the last, from 15 days or a few weeks ago. And now you reach the rectovaginal fascia, and the surgery is almost finished. The advantage of the Rubina is that you can work, you have a clear picture of what you're doing, and if you want to go back to the usual picture, you remove it. You see that the nodule was quite large. This procedure was done by Nicolas Bourdel. And now we check the rectum, and we also showed that using indocyanine green, we are able to assess how well vascularized is the rectum, so how risky we are of complication. And here you have a black part. So it's probably a residual disease. So he decided to excise it because it was not vascularized, suggesting that this could be endometriosis. Okay, and now you look at the rectum. Of course, you have to do a Michelin test at the end of this procedure. You see here the vagina quite well vascularized, and you are able to treat it. So this is a very interesting tool for the future. Why we have this difference between the normal rectum and the abnormal endometric tissue? I think we have this difference because there is a lot of fibrosis in the nodule, and also possibly because of our own surgical technique here in Clermont-Ferrand. You know, we use a reverse technique. We excise the nodule from the vagina first. It means we decrease the vessels to the nodule because we separate it from the vagina. So the part which is not vascularized is much more likely to be the disease because of our surgical technique. But I think this is really a very good tool to assess the limit. So concluding, well, surgeons are mandatory for adequate management of endometriosis. We should not be that much afraid by guys who are claiming that we are dangerous, damaging the ovary, doing unnecessary procedures in young patients. No, we can bring them a lot of pain relief, a lot of fertility results, a lot of pregnancies, if we work adequately, if we learn surgery correctly. So surgery is the only definitive treatment of endometriotic lesions. Surgeons does improve quality of life and is a major tool of the management of the disease, even in minimal and mild disease. And I want to claim that we should teach and protect surgeons. And I want to create a surgeons' welfare organization so that we have surgeons for the future who will take the responsibility of the treatment of this difficult disease. I thank you very much for your attention.
Thank you.
That's okay for me. I'm finished.
Okay, may we call Professor Aguilar for her reaction.
Thank you. Thank you, Professor Canis. It's a very, very interesting lecture, and I agree with you on many points. And we have seen what the best surgery can do for endometriosis. So we would like to address our audience, the Philippine audience, and I will like to bring them closer to the ground, so to speak. So may I share my slides? Short. And this is my slides, Professor Michel, Canis. Pelvic endometriosis, how to perform surgery without harm. So that is my contention. And this is my disclosure that we have received honoraria as a speaker of various pharmaceutical and medical equipment companies, but my lectures are from my own review of the current literature, my research, as well as my clinical experience. And the points that I'd like to bring up is that in endometriosis surgery, we should ask ourselves as a surgeon, and mind you, as a mere mortal surgeon, we certainly are not of the caliber that the Clermont-Ferrand trained surgeons would exhibit in terms of skill. So we are talking to a group of individuals, for example, in the Philippines, who have general gynecology practice, a few who have trained in surgery, laparoscopic surgery, and only far fewer who have concentrated on laparoscopic surgery specifically for endometriosis. So as a mere mortal surgeon addressing our audience, I would like them to be able to ask themselves the following questions. Should you, how will you, and won't you in terms of doing endometriosis surgery? So first, should you? Will the patient benefit from the surgery? For pain, certainly you have demonstrated that this has benefit, and many papers have agreed with the contention that there is a role in surgery for these patients. patients who decline surgery, medical management, I'm sorry, patients who do not respond to medical management, do not tolerate medical management or have contraindications to medical therapy, therefore they will benefit from surgery. Patients who are in acute pain and shall we say maybe in acute abdomen situations, and of course DIE, certainly in proper hands, this will greatly benefit from surgery. But with medical versus surgical, you can see that there are many other contending papers that there's no statistically significant difference in pain improvement between the surgical and medical treatment, so that if the patient would have a choice, the patient should partner with us in terms of deciding which type of treatment should be adapted for her specific case. Pain relief was more prominent longer after treatment in many cases of those who have been treated with medication. What about fertility? Will the patient benefit from surgery? Definitely, if you have concomitant disease and you really have to go in, then might as well take a look at the endometriosis or do something for the endometriosis. Another important indication for surgery is that if you have problems accessing the ovaries for ovum pickup, definitely this will greatly lend itself to surgical management. But mind you that surgery will not decrease the inflammatory markers, and inflammation is actually a equal, if not a greater cause of infertility, and we may not be just correcting the anatomy of the patient to help her fertility. We may have to look for other conditions that may hamper her fertility as well. And look at this table, the promise of pregnancy is not just due to anatomic problems, but also to other risk factors. And highlighted in this table is the patient's age, the presence of chronic pelvic pain, and of course, the concomitant presence of adenomyosis. So it's not necessarily your surgery that may help. There may be other conditions that may pull your success story down. So if you see this old paper by Hamdan, 2015, published in the HumeRep update, showing the pros and cons of surgery, certainly surgery will help produce good outcomes, especially when you're dealing with an ovarian endometrioma that may hamper ART or assisted reproductive technology, but be aware likewise that there may be surgical risks that may cause harm, including impact to ovarian reserve, premature ovarian failure. And for those who are less versed with endometriosis surgery, incomplete surgery and disease recurrence may happen, and it is highly dependent on the surgeon's competency and learning curve. And if the patient is not in a holistic care center where both fertility as well as endometriosis is being managed, or for a surgeon who has no background in fertility management, this may potentially delay the onset of treatment for advanced reproductive technique. So what about malignancy? Definitely, if malignancy is highly considered, then definitely the patient will benefit from surgery. But when we ask the patient to undergo surgery, we have to make sure that what we give as a risk of malignancy is not a scare tactic, but it should be tempered with a research evidence on the risk of the endometrioma being cancerous. Of course, we know that endometrioid carcinoma and clear cell are the most common types of endometriosis-associated cancer, but the excess risk of ovarian cancer among women with ovarian endometriosis translates only to about 2 excess cases per 1,000 patients followed for 10 years. Certainly not reflective of the rate we're doing endometriosis surgery because the patient is scared into thinking that she will develop cancer. So given that, having established a proper context with which we should perform surgery, how should we perform surgery? Of course, this is a PSGE webinar and all of us are advocates. Will you do laparoscopy? Of course. Laparoscopy is the approach of choice, and laparotomy is rarely indicated for benign endometrioma specifically, and this is regardless of the diameter of the cyst and or the associated adhesions. So there is no more cutoff in terms of qualifying which would benefit from what approach. And to guide our surgeons, especially our novice surgeons, to find where and to anticipate where those lesions should be, here's the anatomic distribution. Interestingly, if you look at this table, it's a very nice graph showing that most lesions are ovarian and only a few are in the pouch of Douglas, and only a few, 5.2%, are purely ovarian endometriomas. So you can see a host of concomitant lesions. So when you do surgery, don't concentrate on the ovary, look at other areas as well. Look at this uterosacral ligament. Look at this fossa ovarica. Look for these lesions and you will be able to appropriately diagnose and stage your endometriosis. So which patients will likely have adhesions? This is important to anticipate whether you're going to have a difficult surgery or not. A greater proportion of patients with recurrent endometriosis would have adhesions, probably because of a surgery that has been done or performed long ago where anti-adhesion barriers were not employed, or maybe because it's an open surgery and definitely if a suturing was done. So if you can look at this, most commonly recurrent endometriosis is the highest, you should suspect highest number of adhesions in these patients, followed by previous pelvic surgery. So where are these adhesions located? Look at this. The adnexal region is the most common area where the adhesions are found, but don't forget to look at the sigmoid, the pouch of Douglas, as well as the uterus where even omentum is likely plastered over it and hiding the entire dome of the uterus as well. The challenge of endometriosis surgery is not really the bleeding, but the fibrosis, as correctly pointed out by Professor Michel Canis. Fibrosis makes adhesiolysis challenging, and that's why cold knife excision is ideal because you rarely, if you enter the proper plane, need energy. Energy may actually, with lateral spread, cause more damage. Cold knife excision is ideal because you will encounter less bleeding and provide less damage. Here, I am telling you about haptic feedback because haptic feedback, apart from indocyanide green, is one important thing where it will help us guide us where the area of fibrosis is and where to excise and to distinguish from, say, vessel or bowel lesions. Will you call a surgeon? Certainly, especially when you're dealing with deep pelvic endometriosis here. And if they're digestive or bowel lesions, definitely surgical management should be inputted early on, even prior to surgery. Will you remove the ovaries in end-stage endometriosis, meaning for patients who no longer want to conceive? Well, this is how to counsel your women. Your women should be told that most women rarely develop ovarian cancer. The increased likelihood of ovarian cancer is there, but the likelihood that her developing ovarian cancer is low. The patient should be aware, but not worried about endometriosis. And only 1.3% of women will develop ovarian cancer, and still less than 2% of women will develop cancer with endometriosis. So though the risk is increased, the lifetime risk of a woman is quite low and not substantially different from that in women without endometriosis. So put it in proper perspective, always compare their risk to the risk of breast cancer, which is 12%, lung cancer 6%, bowel cancer 4%, risk of ovarian cancer less than 2%, and tell them that endometriosis-associated cancers tend to be detected at an earlier age, and they usually have better prognosis than other types of ovarian cancer. Won't you? Will you give pre- and post-op surgery adjuvant treatment? Will that help you in your surgery? appropriate preparation is required, and post-op care is likewise needed. But there are many papers regarding pre-adjuvant, pre-operative strategies. For the paper of our esteemed professor, here, it is an ESHRE recommendation for the surgical treatment of endometriosis, just published this year in the middle of the pandemic. I suggest to the audience to please get hold of this nice paper, Preoperative Strategies for Safe and Complete Adhesion of the DIE has been recommended, but there's no recommendation for pre-op adjuvant treatment, meaning do you give GnRH? There's none. But for the previous paper of Saridogan and other workers published in 2017, this is the first part of the current paper. They say that if the procedure is too difficult to perform by laparoscopy, it is better to stop the procedure, drain the endometrioma, and prescribe GnRH and go back to fight another day, maybe 3 to 6 months later. But this two-step procedure is expensive and the woman may not agree to a second procedure. So if there is an anticipated problem, then refer the patient to a center where necessary surgical expertise is available. Regarding post-op fertility, will you give adjunct treatment? There are many papers currently available for that. One is that GnRH agonists may preoperatively have a negative effect on the natural pregnancy rates of patients after surgery with ovarian endometriomas. So we have to consider that not all women will go into ART. We want them to be able to conceive naturally, especially for young women, and we should be aware of the possible negative impact of preoperative treatment on these women. How about the symptoms? Prior to surgery, pre-treatment may be necessary while the patient is waiting and the patient may be in pain. This is a comparative study showing versus one medication, which is progestin, and another, which is GnRH agonist. There is a similar results regarding surgical duration and blood loss when you use either of the medication, but you will have less symptoms of hot flashes, of course, in a woman who's got the progestin group, was in the progestin group, and there's greater incidence of metrorrhagia in the progestin group. So you have to tell your patient which side effect she will tolerate so that you will be able to individualize your care. So will you have a multidisciplinary team when you attack a surgical, when you perform difficult surgery for endometriosis? The answer is yes, but try to organize early as possible locally. So these are the tenets. The surgical team should be organized to the needs of the planned or anticipated procedure. You may want to have this on hand: a bowel surgeon, a urologic surgeon, a thoracic surgeon, especially if you're diving deep into the DIE, and pelvic vasculature may be involved, and lastly, a plastic surgeon, but that needs to be qualified, especially regarding the extent of the surgery you intend to do. The gynecologist, of course, should lead the team. We are the captain of the ship because the gynecologist understands endometriosis and is able to correlate the woman's symptoms with the anatomic pathology and will be dealing with endometriosis on a longer term compared with the other surgeons. So the gynecologist will act as an advocate for the patient, and the unique care plan should be set up not just with the team but the patient as well, who would want to have a better quality of life after the surgery. So here are the tips. Get an input from other disciplines related to the technical aspect of the procedure. Hold a multidisciplinary team meeting before the surgery and notify the team in advance so that the procedure will be held at a time when everybody is available. Please try to avoid stat referrals. So in summary, as a mere mortal surgeon, we should be able to answer these questions before we dive into endometriosis surgery. Should we do only properly indicated surgery? How will we? Do laparoscopy, of course. That should be the main approach for endometriosis surgery. And will we or won't we? We should. We should train and prepare for and perform good surgery. If you're incapable of doing so at the present time, and we have yet to receive our training or preparation, we have to otherwise refer. So I end with this very interesting quote from our professor, guest, Michel Canis. I will try to read it in French, so pardon me. C'est un sujet que les chirurgiens est l'ennemi de l'ovaire. I practiced that the whole day, l'ennemi de l'ovaire. So before I murder the French language further, or if Professor Michel will be rolling over in laughter, I will give you the translation. Some suggest that the surgeon is the enemy of the ovary. So that is the contention or opening statement of his paper. But he contends the following. I will no longer read this and attempt to speak French, but this is the translation. There is no reason to ban or fear surgery, but you have to organize and teach. That is our passion and that is our mission in PSGE, because we want everyone to approach endometriosis surgery and for all gynecologic surgery for that matter, because we want that it be done correctly. With that, thank you very much. Good day and stay safe.
Thank you, Professor Aguilar, and also would like to thank Professor Canis. Now the floor is open for our Q&A. Dr. Jing Fernandez, are you ready to join me for our Q&A?
Yes, Dr. So for the first question, maybe we could ask Professor Canis. We are very much interested with the indocyanine green, or the ICG. And the question here is, how do you actually give the ICG? Is it, or where is the point of entry of the dye? At what point in the surgery is it introduced, and how much is actually used?
Okay. To assess the vessels of the rectum and or of the ovary, you have to inject it intravenously. And you inject it really just when you need it. That means when you almost finish the surgery and everything is prepared, or when you are excising the nodule from the rectum and you need to see the vessels, then you ask the anesthesiologist to inject it. And the dose will be in the paper published soon in Fertility and Sterility, but this is the standard dosage, and it's very useful. It's used commonly, for instance, by ophthalmologists. So this is not a new drug. This is a very old drug that we are discovering as gynecologists, but you inject it in the veins, in the vessels.
Okay, so how much is actually used? We will see that in the paper when it comes out.
Yeah, I will go to the slide and try to show it for you. So we inject 5 milligrams per kilogram. Okay.
Okay, There's a question here. This is a special case. This is both for Professor Canis and for Professor Aguilar, meaning how do you go about it for an adolescent with severe pelvic pain? And you have already ruled out all of the possible causes, like the Mullerian anomalies, okay, for this pain. Then you're thinking most probably this is a pelvic endometriosis. In your country, how do you go about it? And in our country locally, I also like to ask, and there's a question here, how do we go about it here in the Philippines?
Professor.
You want to answer first, Professor Aguilar?
So how do we go about the treatment of?
Adolescent patient with pelvic pain, and you're thinking of this might be a pelvic endometriosis. Adolescent.
Definitely, this is my advocacy, and I'm one with the world in advocating for a medical trial first. Certainly, we would like to discover the underlying pathology for adolescents, but if the pathology initially can be cured with medical management, then we really would be uh, uh, we would really appreciate the fact that the adolescent would respond. Not all adolescent dysmenorrhea is due to secondary dysmenorrhea or endometriosis. Intractable pain may lead to the laparoscopic investigation, certainly, but still medical trial or conservative management should be the order of the day.
I fully agree with you. Medical treatment should be the first approach. But many of them are diagnosed as having endometriosis, whereas we have no proof that this is indeed endometriosis. We should manage them because they have severe pelvic pain, severe dysmenorrhea, and we should listen to the pain, okay, and treat it and manage it. But we should not say to them, okay, you have endometriosis, we don't know yet. And if the treatment of the pain is too difficult using a medical approach, I think we sometimes should do a laparoscopy to check whether or not they have the disease. And sometimes, you know, when you don't find nothing at laparoscopy, which is not so rare, there is no endometriosis, they feel much more confident and they are very reassured because they are not afraid, any longer afraid of the disease. So I think, okay, laparoscopy is not the first approach. I fully agree with you. But when the treatment is too difficult and when anxiety is becoming more and more severe because of this worsening disease, I think sometimes it's good to do a laparoscopy, to treat the disease if it's present, to say there is nothing if there is nothing, and to give correct information to the patient. But please don't tell them they all have endometriosis. It's not true.
That's true. We agree.
Thank you.
So I have a question for Dr. Aguilar or Professor Canis. In doing deep infiltrating endometriosis surgery, do you actually do a bowel preparation? And if so, what do you use?
Professor.
Yes, please go.
Well, definitely, I want bowel preparation. You know, in SAGES, the American AAGL, they say no more bowel preparation. But when you're doing an endometriosis case, we want to be prepared for the worst, and we don't want to be distracted by bowels coming in and out. We're not doing gallbladder surgery. Endometriosis is a very difficult condition. You can get lucky and have simple cases, but you can get a small cyst, but when you come in, you can barely see anything. And we want bowel preparation to be our ally, sir.
I think you're right. It makes exposition easier. It also makes management of complication much easier. And although bowel surgeons are quite reluctant about bowel prep today, they think it doesn't decrease the risk of complication. It may be right, but I think it makes management of complication much easier. And also it facilitates the exploration of the rectum and of the sigmoid. It's not so easy to find deep lesions sometimes. Some of them may be difficult to find because it's only a small retraction, as I showed. And it's even much more difficult if the bowel is full of feces. So we do agree. Okay.
For our two professors, again, this question is for both of you. Now, in relieving pelvic pain for patients with superficial endometriosis, okay, have you ever, do you have this kind of study whether which is more effective, the sharp excision of the lesions or the fulguration or ablation? Which of these two, did you have any study about it, that which is more effective in relieving pain for superficial endometriosis related?
I think there are prospective studies comparing both methods and found no difference. I still would recommend to do excision instead of coagulation for a very simple reason. First of all, if you do excision, probably you are more able to diagnose deeper lesions which were not visible from peritoneal inspection. This is the first reason. And the second reason is if you want to do excision for deeper lesions, you need to train. And superficial disease or early cases are very good training cases to get trained to be able to do more difficult procedures afterwards. So that's the reason why I would recommend to do excision as much as possible. You train and you do a better diagnosis of early deep lesions.
Yes. Yes, I agree. And ever since I understood the pathophysiology of endometriosis, as well as to be able to appreciate the power of electrosurgery from my good friend, Dr. Angel Tan, I would rather refrain from doing coagulation or electrosurgery left and right because rather than help, it may do more damage. Excision will definitely be a better way of extirpating those lesions. But then again, it may be temporary. So you just hope it won't recur. But according to Professor Michel Canis, it may not be a recurrent disease. Certainly, there's a lot of phenotypes of endometriosis out there. So there may be intractable disease. There may be patients who you see with superficial endometriosis that is practically an incidental finding. We don't know if there's such a phenotype, or we may be observing a different phenotype from those with more, shall we say, virulent phenotypes or difficult disease.
Okay, thank you.
This is a question from Dr. Bautista. Please comment regarding transvaginal sonographic diagnosis of deep infiltrating endometriosis using IDEA standards, or and how does it correlate with the laparoscopic and diagnostic or treatment in the, I'm sorry, how does it correlate with the laparoscopy, especially in the diagnosis and treatment of endometriosis?
Well, that's very simple. As for any imaging technique, if you have a trained radiologist, he will give you very reliable information. And if you have a non-trained radiologist, information will be useless, because the non-trained radiologist will be able to see the cyst and that's all. And the trained radiologist will be able to tell you whether or not the submucosa is involved. And depending on this, you have a good approach of what to do before surgery, or you go for an adventure. And I think we should not go for an adventure anymore today. We should have very trained radiologists working with you. It may, when you begin in this kind of surgery, you will have to train the radiologist to explain him what you are looking for, maybe to ask him sometimes to come in the OR to see the disease with you so that he understands what you are looking for. And after 1 or 2 years of training, generally, it will bring you very valuable information, and you need it to plan the surgery correctly. Train your radiologist.
Yes, that's good. I'd like to also add that don't forget your rectovaginal examination, sir, right? For DIE, you know, sometimes we do ultrasound left and right and we forget or omit that. So there is a classic, very simple, low-tech way of looking for that DIE. Don't forget your RV examination.
Precisely. Now, this is a question from Dr. Marcela Carlos. What are your criteria for surgery for endometriotic cysts?
Well, we do operate, first of all, persistent cyst, because many hemorrhagic fluid endometriotic cysts are in fact chocolate functional cysts, which are not endometrioma. So first of all, operate only persistent cysts, because if they are small, if they are here for 2 months, it's not an endometrioma. It is a functional chocolate cyst. I just want to remind you that a long time ago, Dan Martin did the study about chocolate cysts at laparoscopy and found that 1/3 of them were functional cysts and not endometrioma. And that's the same at ultrasound. And the second is we don't do surgery in small cysts of less than 3 centimeters in diameter. We do surgery if we operate a patient with severe pain and small cyst, we treat the small cyst, but we don't indicate surgery just for a 3 centimeter cyst. We wait for 4, 5, 6 centimeter in diameter cysts.
Okay.
Same answer with you, Professor Aguilar.
It's okay. Yeah. Same. To Dr. Diane, Carlos, it's okay. We really have to be selective in our surgery, and let us not do surgery left and right, especially for small cysts. We can find out whether it will be responsive to medical treatment or just so that we can observe. And we have to find out whether our surgery will benefit the patient or not.
So here's another question for either of our professors. For bigger cysts that we have to operate on, sometimes there is a need to leave behind the cyst wall, especially if it's too stuck at the hilum. And of course, we don't have the other measures to check for closer involvement, but with the use of the bipolar, what is, in your experience, the recurrence rate of this left behind cyst wall? And if you will use bipolar, because you said it's better than the monopolar, what setting do you usually use for it?
You want to answer, Professor Aguilar, first?
Professor, I'm going to copy your answer. No, just kidding. What I would like to say is we just use the lowest wattage possible. Like I said, electrosurgery is a very powerful tool, and we have to make sure that there's less harm, more help. So if you can do with 20 watts, 25, do so. Minimize charring, because charring is the one that will cause additional adhesions in the future. So that will be my tip for using bipolar. But if you can be more precise, if you can try to do just excision, do away with the bipolar, or make sure that you're in a proper plane, then you don't need to use energy at all.
Yeah, I agree. For the treatment of cysts, you really have different situations. If you have a 42-year-old woman, you should excise all the cysts because you are here to treat the ovary and to prevent the risk of malignancy, no further to preserve fertility. If you have a 25-year-old woman and you think you are going to damage the ovary, it's better to leave part of the cyst wall behind. And don't be afraid to leave part of the cyst wall behind. You may be able to refer her to a department where laser or whatever alternative to excision would be available. I don't like very much bipolar coagulation to treat the remaining part of the cyst wall, because bipolar coagulation, you have a lot of problems to control the depth of the damage that you induce. And if you want to use it, of course, you should use low voltage, but I think the most important point is to use very short application time, less than 1 second, to make sure that you are not coagulating deeper to damage, taking the chance to damage the ovary. This is a very important point, very, very short application point. And treat only glandular area, not all the cyst wall. Try to treat only the glandular tissue. Otherwise, you will do a lot of damage. If you can't excise, it's probably better to leave part of the cyst wall behind and to refer the patient to another department afterwards.
You can still entertain one more question before we wrap up.
Okay, so we know that endometriosis is actually associated with pelvic adhesive disease, and it remains to be a major public health, as you have stated in one of your researches, Professor Canis. Do you have actually preferences for anti-adhesion products?
Yeah, we use anti-adhesion products in many cases, and generally we use Interseed, which is an old product, cheap, easy to use, easy to put in place, and we use Interseed when we use something. Or you may use Yellow Barrier, which is also an alternative. Unfortunately, there are no comparative study of these different products. On that, I want to raise another technical point. To prevent recurrent adhesions, you have to excise the disease. Everyone is speaking about the rules of microsurgery, minimal tissue, gentle tissue handling, careful hemostasis, and so and so. But the last rule of microsurgery is complete excision of abnormal tissue. If you don't do that, the disease is still there and the adhesions are going to recur, obviously. And it means you have to treat the ovary, but you also have to treat the peritoneum of the broad ligament under the ovary to try to decrease the risk of recurrence. And after, you can use Interseed around the ovary, or you can use other products if you want.
Okay. It's really, we really don't want to end this great webinar. We really had very great speakers, and but we still have to wrap up. So before we wrap up, we would like to call our equally brilliant and hardworking Vice President, Dr. Tonette Habana, for her closing remarks.
Hi, good afternoon. I hope you can all hear me.
Yes.
Yes, okay. Hi. It has indeed been a very interesting afternoon. No? Excellent lecture by Professor Canis and the shared perspectives and views of Professor Aguilar. I would like again to thank our faculty, Professor Michel Canis and Professor Angela Aguilar, our chair, Dr. Jean Godu and Dr. Asuncion Fernandez, and our president, Dr. Prudence Aquino and Dr. Ney Abat. I would also like to thank all our participants for attending this webinar. You will receive a survey after this session, and your feedback helps us choose topics that are relevant to your practice, and your input is greatly appreciated. A post-test also will be sent for CPD requirements. The session has been recorded and will be available in the website of PSGE in the near future. The last webinars are already available in our website. This webinar, as mentioned by Prudence earlier, is the first of a three-part series of webinars supported by an unrestricted educational grant from Karl Storz Endoscopy Philippines. Again, thank you, Karl Storz, especially Claire, Lawrence, and Henry. The next webinars will be on the following. If I can have the slide. This would be on September 2 at 4 to 6 p.m. It would be on the systematic approach to total laparoscopic hysterectomy. We have as faculty Professor Helder Ferreira and Dr. Herman Tan Cardoso with the chairs Dr. Ana Belen Alenzuela and Dr. Marinela Abat. On September 9 at 3:30 p.m., we will discuss management of ovarian endometrioma. So more of your questions then with Dr. Delphine Tan and Dr. Clarice Hack. This is supported by an educational grant from JCS Pharmaceuticals and again Unilab and Biopharm for the platform. Our chairs then would be Dr. Gladys Tanangonan and Dr. Jane Fernandez. And the third and last KS webinar will be on September 23. That would be at 8 to 10 p.m. For our faculty, we'll have Dr. Joan Tan Garcia and Professor Rudy Campo. Our chairs then would be Dr. Ann Trinidad and Dr. Gladys Tanangonan. Unfortunately, we cannot ask everyone to open their screens for a photo op, but I would like to ask the panel for this one. Again, thank you so much. And this concludes our webinar for today. We hope to see you again in our next webinar. Okay, thank
I
you.
open myself.
Yeah,
I
can
cannot
you
open myself. You have to
Lawrence,
Lawrence has to open.
unmute me. There. There.
Who's Professor Canis too?
You need to open your.
Jean, Angge, Jing. Yeah, there you go.
Ma'am, host
Everyone.
stopped it. Host stopped my video.
Even mine.
Hold on, hold on.
And there's Henry.
Hurry up, Henry.
Yeah.
Where's Professor Canis?
There you are. Yes. Thank you. Thank you so much.
Mercy, salamat, salamat. Mercy, thank you.
Maraming salamat. Can you say what Angge was trying to flash earlier?
Oh my God. Professor, I'm sorry I murdered the French language. It's beautiful, but...
Unmute yourself.
You did well in French. You did very well in French.
Yeah. L'ennemi. De l'ouvert. That's all. So merci. Au revoir.
Jalen, can you be the one to take our picture? You're not seen.
Okay po, Doc.
Okay.
1, 2, 3. Isa pa po.
Okay.
One more. Ups. Okay pa.
Thank
Okay,
you.
thank you. Thank you so much. Thank you. Bye. Have a good evening.
Salamat.
Nice meeting you. Salamat.
I'll email you. Thank you. Bye-bye.
Thank you, Professor
you.
Canis.
Thank you, everyone. Congratulations
Thank you.
po.
Yeah,
Thank you, Henry.
everybody was so happy. Thank you for Angge. Thank you so much. Tonet, nako.
Buti nagpatawa ako. Salamat. Hindi siya ngumingiti. Nung nag-French ako, natawa. Joke lang.
Thank you.
Pastor, thank you.
Thank you po. Thank you po. Stay safe and healthy.
Thank you.
In our
Yes.
next
Thank you
face
po.
Professor sometime in a couple of years.
Yeah, we hope to invite you again in
Yes.
person this time.
Yes, in person again.
In person. We'll do surgeries here again.